It's been about 4 to 6 months since Beverly had her anterior teeth removed and grafted the sockets and the implants were placed. And over that time, we've been working the provisional restoration to create what would be a good soft tissue frame, a soft tissue replica, so that we can make nice ponics. The other thing is the tissue around the implants has healed very nicely. And she's been in this provisional now, and we've adjusted the occlusion. We've adjusted the ponics a lot because we wanted to create nice soft tissue around where the ponics are. And we wanted to preserve our interdental papilla, which is critical when we're making ponics or if we're doing something around some implants. We want to preserve that. And so our provisionals then, actually, I like to refer to the provisional as something that helps us to gain tissue health. Sometimes we want to just maintain tissue health, but in this instance we want to gain some tissue health. And Beverly lost her teeth because of periodontal disease, but what's nice about the bone graft that we placed in the sockets of 7 and 10 is they supported the bone on the mesial of 6, the distal of 8, the distal of 9, and the mesial of 11, and as it filled in, those teeth now are just rock solid. The other interesting thing is we made a 6-unit provisional instead of 2 3-unit provisionals. And I think this is important also, to splint as many teeth together as you possibly can, so that when we make our final impressions for our crown and bridge, even though we may make it in 3-unit bridge segments, the 6-unit bridge is going to keep those teeth in the exact position that we recorded in our final impression. Let me say that again. It's going to keep the teeth in the exact position that we recorded in our final impression. Now, this whole course that we're talking about is about fixed and removable. One of the things we'll talk about is bar partials. When you make a bar partial, you must make a fixed provisional where the bar is going to go. What that does is it keeps those teeth in the position, just like with ponics, so that that bar fits perfectly coming out of the lab. If you do 2 single units, the bar is never going to fit. And partly because the teeth are going to move during the time in which the crowns are being fabricated and the patient's functioning in those teeth. Let's take a look now at what we've been able to do over the last few months with our provisional and our provisional partial in Beverly's mouth. And then today, I want to show you some techniques on using a transfer base and how to cement these provisionals using our cementation technique. Okay, let's go to Beverly's mouth. The provisional now has been in for a while, and what you'll notice with the provisional in, we've got nice, sharp, pointed interdental papilla on either side of the ponics, between the central incisors, a critical position, on either side of this ponic, and our implants have integrated, and I'm going to make a little tap, okay? And they sound rock solid. If we tease this provisional off, I don't have it cemented at this time. What you'll notice now is our ponic sites have been developed. We've got really nice attached gingiva. It's about the height that you'd like to see a lateral incisor. It's in line with the heights on the prepared teeth. And in essence, we have preserved and maintained our interdental papilla. What I want you to take a very good look at, right in between the central incisors, and what I want you to notice is how the interdental papilla has formed on the lingual and out on the buccal. And there's a little concavity between those two. That area is called the caul, C-O-L-L. And we've worked really hard in our provisional to create a shape that produces this. The other thing I want you to notice is our preparation has allowed us to go subgingival and support that papilla. If I take my periodontal probe and just lightly touch that, you'll see that the line angle of the provisional is going to come right out from under that. Now, Frank Spears and John Coyce talk about the whole idea of the water bag, or actually putting pressure on the interdental papilla. Without that pressure on the interdental papilla, the papilla will seek an area that will support it. So if I slide our provisional back in, what you'll notice right away is that interdental papilla now is supported by that line angle right there and that line angle. As we move over to the ponic area, you'll notice even though there's not a root of a tooth, the ponic's line angle is supporting. Now, if you listen to the teachings of Walter Gephardt, he refers to the zenith of the teeth. And for a central incisor, the zenith should be right there and right here. And as you'll notice, this line angle comes right to the zenith and disappears under the tissue. This line angle comes right here and disappears under the tissue. And they come together here right at the long axis of the tooth. Right at the long axis of the tooth. So our zenith on a central is in this area. On a lateral incisor, the zenith is dead center. And on a canine, the zenith is dead center. In fact, Walter refers to a lateral as a baby canine, or a baby canine as he calls it. So the support of this soft tissue is critical. However, lab technicians will tell you if the teeth are not prepared with a zenith in the prep, I would want the zenith of my prep here that will come around and come incisally, but I still want to be below tissue enough to support my papilla. So there again, my preparation is not quite as deep here. It's deeper here, creating a zenith in my prep. Same way with the canine, same way with this canine. With the provisional out, it might be a good opportunity for you to see how well the tissue has healed actually on the lingual of the tooth. And I'm going to use this big mirror. So you can see the implants now. These are just little healing caps. These are Noble Biocare 4.3s, little healing caps. And the soft tissue around the healing caps is beautifully healthy. You'll also notice that the tissue on the lingual of the provisionals is really, really, really very, very healthy. And part of the reason is because the temporary partial has been relined over the tops of the healing caps. Now, we put these healing caps in the day we did the immediate placements on these. It's also the same day we grafted the ponic sites. And during the time that Beverly has been having these in there, one of them came loose. And it came unscrewed. And so she came in, she had it in her hand. She actually thought maybe her temporary was out, or the whole implant was out. Kind of freaked her out a little bit. And so the tissue, just in the one day that the healing cap was out, had just completely collapsed over it. And for me to even get the healing cap back in there, I had to numb her up just to be able to screw it back down. So you can see those tissue changes are quite rapid. And so when you're trying to record these, maybe in an impression, or when you're making a final impression for your crown and bridge and you've created a ponic site, one of the things that Kathy and I do is we keep the provisional on the teeth just as long as we can, even if we have retraction cords in, so that it will maintain that tissue support until the second we're ready to inject our Impergum into the sulcus and onto the soft tissues. Okay. I'm going to slip my provisional back in. And I would encourage you to spend as much time as you possibly can on working that provisional and working the ponics. Take it in and out as many times as you need to. It will ensure a much better aesthetic result, and I think a much healthier tissue in the long run. Here's her little temporary partial. And as you can see, it's going to fit right to the temporaries. Now bite down for me. And so the temporary partial now has served its healing purposes for us, but it's also given her something to function with during the process. Now, this is the transfer base that we're going to use when, go ahead and close for me, when we're going to use when we make our final impression. And that's what we're going to be doing next. We're going to be making a pickup impression of our crown and bridge. We've already made the final impression for the crowns. And in that final impression, we used this transfer base. If you'll notice, the transfer base has got some little bite blocks in the back, and it's got notches cut into the transfer base so that we can take a bite record with her provisional in. And see, that's critical, because what I want to be able to do with the lab is send an approved provisional model that they can mount interchangeably with the die model. This is really the benefit of a transfer base. And in a few minutes, you'll be able to see a video on exactly how to make one of these. I'm going to show you how to make one of these. You may want to take an impression of the provisional, since we've got some time in this 4-month healing window, and make your transfer base off of that impression. Many times we'll do that. And when we put the transfer base in, let me show you how it fits. What you'll notice is there's a cutout in the transfer base of where the implant is. The other thing you want to make sure is that you have clearance so your transfer base is not touching anything. So that transfer base fits passively in the mouth. I've got just a tiny bit of powder adhesive in it. It's made out of triad, and it's going to serve for us. It's basically fake back teeth while we make this case. So when I feel like the occlusion and the provisional is just right, soft tissue is ready to go, we'll put this transfer base in, and we will take an impression of the provisional with the transfer base in and pour a stone cast in it, and then the lab will have a way to make an approved provisional model that has a removable transfer base. We'll then put it back in her mouth. We'll make an impression of the prepared teeth and the implant impression analogs with this same transfer base in the mouth. The lab will then use the same bite record, and so they can mount the approved provisional model and the die model with the same bite record off of the same face bow, and that will allow the lab to have interchangeably mounted models. That's the other real benefit of a transfer base. How would you take a face bow on a patient that doesn't have any back teeth and all they've got is 6 anteriors? You could put some putty on your face bow for it, but you're not going to have the plane right. We make our face bows with the transfer base in the patient's mouth. That way, we can always mount that approved provisional model using our transfer base on the face bow. It makes sure that we have our plane horizontally and anterior-posteriorly just right. What you can see is the approved provisional is in, the transfer base is in there, and as you can see, there's a large cutout in the transfer base around the healing cap. Because when we make our final impression for our crown and bridge, I can take the provisional off, I can drop these implant healing caps out, screw in an impression coping, and take an impression of the crown and bridge and an impression for the custom abutments, and pull the transfer base all at the same time. What that'll do is my transfer copings now are right in the same impression with my approved provisional and my die models. So that makes everything interchangeable. Let's do one other thing, Kathy, and it'll kind of be a messy thing, but let's look at the occlusion on these provisionals. Because one of the things we want to be able to do, it's all great and good to have pretty healthy gum tissue and to create these nice interdental papilla and everything. But the bottom line is we have to create a really good occlusal scheme, because one of the functions of anterior teeth is to protect the posterior teeth. And I wanted to protect these implants, and I wanted to protect the partial in the back. So we want to work out all the anterior guidance. And we want to work out all of the centric stops. So we have what Dr. Dawson would call stable holding contacts. And so her provisional is not cemented, and typically we'd be doing this when it's cemented. So I'm going to hold it in place. Go ahead. And tap together for me, Beverly. Tap, tap, tap. Okay. Now let's do the other side. Tap, tap, tap. Okay. Didn't get much of a mark. Let's hit it with blue. Tap, tap, tap. Okay. And again. I think the blue might be easier to see, actually. As you can see, we've got stops. We've got stops primarily on the canines, where the canine and the lateral come together, which is a good thing. And then we've got little light anterior stops all the way around. Okay? Now slip that out, and let's use the ribbon again. And Beverly, here's what I want you to do. Tap, tap, and then grind around in circles for me. Forward and back, side to side, okay? Tap, tap. Side to side. That's it. Bite down again. Forward and back. Come out on the edge and slide back. There you go. Now, if you'll recall, one of the things I believe strongly is that you have to have a stable holding contact in protrusion, which means the incisal edge of these provisionals has got to be wide enough to accept the lower incisal edge. And that patient should be able to hold there and slide back. And that's a great way to check your guidance. Most of us learned in dental school to tap and slide out. Tap and slide out. There's no functional movement in what a human being does to hit and slide out. As we bite a piece of pizza, we come out on the edge of our teeth and slide back. And that's what protective occlusion is. So if we look in Beverly's mouth again, as you can see, her guidance when I got her to go round and round is primarily canines on the central, canine on the central. Then when we get out here onto the anteriors, we've got a stable stop in protrusion, and then we slide back. And that movement's only about 4 millimeters. By then, she's bitten off whatever she's trying to eat. It's in the back of her mouth, and now she can chew. And so this protective scheme looks pretty good. The nice thing about a patient wearing a provisional a long time is that during that period of time, a patient's going to eat, drink, and be merry. But at the same time, they're going to grind in their occlusion for us. They're going to work those lower teeth against that acrylic, and it's going to show us where we need to adjust, how steep does the guidance need to be. So don't miss the opportunity to record that and actually discover it, if you will, during the process of the tissue healing. Sometimes we'll make 2, even 3 provisionals before it's all over with. In fact, this is Beverly's second provisional. Seems like it may be a huge expense, but the bottom line is, I know by doing that, I'm going to get a predictable result in my porcelain. And you're not going to have a patient that's always on your doorstop with chipped porcelain on the front of their crowns, and you got a big bridge, and work it all out now. Take your time. If you don't think it's just right, make another provisional and keep working it out. Once you feel like that's just right, the patient's happy with it, it works good, now you can record it, and then the lab can duplicate that for you. Okay. Let me show you now something that is really a terrific cementation procedure that we've done over the years. I have a lot of dentists around the country ask me, what do you cement your temporaries with? I always tell them Duralon. It freaks dentists out when you tell them that you're going to cement temporary crowns with Duralon, because Duralon is a final cementing agent, and if you've ever had to clean the spatulas after the Duralon has set on them, it's almost impossible to get it off. Well, I learned this from my daddy way back in the 70s when I was working for him as a dental assistant. And he didn't like temporaries coming off because he didn't want to have to go down to the office on the weekends and put them back in. which you can't really blame him. So he started putting his provisionals in with Duraline. I modified it a little bit while I was in dental school to use copalite or cavity varnish on the prepared teeth. So let me give you a quick rundown of how it works. We put 2 to 3 coats of copalite on the prepared teeth, and then we put a small amount of Duraline inside the provisionals. We let it set. Clean it off. Patients' provisionals will not come off. If they do come off, they're usually broken when they come off. And that should be telling you something right there. This one thing that I'll teach you today will be something that will really help you out over the years. Now, you'll only forget the copalite once because the Duraline really sticks. When the temporary comes off or the provisional comes off, many times the Duraline is stuck on the teeth, and all you have to do is take a scaler, push on it, and it comes off in big sheets. Because you see, the Duraline sticks to the copalite, and the copalite lets loose from the tooth and allows the Duraline to come off. Duraline also has another property that's kind of interesting to me. The polyacrylic acid and the polycarboxylate cements, they have a very quieting effect on the teeth. The pulps seem to behave better. I also think it seals the whole provisional up better. My dad used to say that the Duraline pacifies the pulp, and frankly, he's right. So, combination of using your copalite and your Duraline, your temporaries won't come off, and the pulps and the dentin of the teeth will be healthy. I always get a question too from participants that ask me, what about the copalite on those teeth, and if you're using a cement that has some sort of bonding to dentin? Typically the copalite is pulled off with the Duraline when the Duraline's taken off the teeth. In many instances, we don't anesthetize a patient to put in their final crowns because you just don't have to. You may run into a hot tooth or two, but typically we don't. And if you feel like that you're using an adhesive cement and the copalite could be an impediment to your bond, just use some Duraline liquid in a rubber cup and pumice those teeth, and the polyacrylic acid of the Duraline liquid will clean all of the copalite off the teeth. It'll almost look like an etched tooth. The other thing you could do is just use some pumice, some flour pumice and water, and prophy those teeth. And then my friend Tom McDonald, he uses a little bit of phosphoric acid. He just puts a little phosphoric acid on the teeth, etches them, and feels good about the copalite being off. Okay, so let's go through the process and I'll show you exactly how, by cementing these provisionals that we're all finished with onto Beverly's teeth. I'm just going to lightly dry these preps with a little cotton roll. And what Kathy will do is she'll hand me one of those little quick tips, close down a tiny bit, open back up a little bit. And we put some copalite out in these little wells that we put bonding agent and stuff. And it gives me a nice little reservoir to use as quick tip. And if you'll notice, I'm being very liberal with my copalite. And I would recommend that you'll put 2 or 3 coats until you have a really nice glistening surface. Because this is going to be your separator when you're ready to clean that cement off. If you have an alloy, maybe a large amalgam buildup, an alloy buildup, I'd recommend that you put several coats because the alloy has a tendency to really stick to the Duraline. We got a pretty nice shiny surface, and I think we got about 3 coats of copalite on there. This is copalite. It's cavity varnish. It's the stuff we learned in dental school to put under alloys. I still use it under my alloys. It provides a space for the corrosion of the alloys and helps to seal the alloys up. But it's a great separator for this purpose too. We use a lot of this stuff. Okay, Kathy has put some Vaseline on the outside of the provisional bridge so that the Duralon will come off a little bit easier on the outside. And we've put a little bit of Vaseline on the temporary partial. And she will just put a little bead of Duralon around the inside and the gingival portion of the provisionals. A little bit of Duralon in the provisionals. And then we'll put this to place with a good solid push. As you'll notice, there's not going to be a lot of excess because we didn't load the provisional up. Most of our excess will probably be in the lingual. Not too bad. See how Kathy hands me this little quick tip? I'll very quickly remove the unset Duralon from the lingual of these. And then we'll place our provisional partial in. Bite together for me now. There you go, thank you. Now that partial is going to serve as a seating matrix. Open for me now. Then I'll take a little cotton roll. Bite down now. And we'll let that set for about 7 minutes. The cleanup of this will be very easy because of that Vaseline. And always put a little bit of Vaseline on your interproximals. You don't want a bunch of Duralon built up in those interproximals where we're trying to create those really nice interdental papillae. And so the Duralon would be a real irritant if it was down in there. In the old days, we used to take a piece of floss and put that down in there and tie knots in them so that when we clean it out, we just pull the floss through. I cemented the floss too many times under the temporary, so we quit doing that. Okay, I'm going to slip this out, and we're going to let Beverly relax while that sets. Now we've got the cement all cleaned up, and Beverly's ready to go. Take a quick look. Our provisional's back in place. Temporary partial is anchored to it real well. Did you adjust that at all? No, it comes right out. Okay. We're going to be protecting our implants and preserving our soft tissue and give her something to eat with. And so here she is, all in plastic, shall we say. All in plastic. Bite down for me now. I feel real good about the color. I feel real good about the function now. We've changed the function a good bit, and her temporary partial is going to help us protect those implants. The next time we see Beverly, I'm going to demonstrate to you how to use that transfer base in the final impression procedure, but I'm also going to have the final crowns to show you how to pick up the crown and bridge and use your transfer base in the modified Applegate technique, which is one of the things I really want you to get out of this weekend.